Good evening, everybody, and welcome to this evening's Facebook Live. My name is Alec. I'm the Managing Director for Wound Care People. Most of you, I'm sure, will recognize me from some of these events. This evening's session is Removing the Barriers to Wound Healing Through Simplification. And tonight's session is sponsored by Coloplast. So I'd like to first and foremost say a huge thank you to Coloplast for supporting these events. We've got some wonderful first-time speakers with us this evening, some very well-known speakers, but the first time they've ever worked on the Facebook Live with us. So we've got the wonderful Simon Barrett, who's the Tissue Viability Lead Specialist Nurse for Humber Teaching NHS Foundation Trust, and Donna Welch, who's the Podiatry Operations Manager and Professional Lead at City Healthcare Partnership. Simon, Donna, how are you?
Very well, thank you, Alec. Thank you.
Good, thanks.
Aside from the tribulations we've just been telling each other about before we went live. So as always, these events work best when people engage with us. So please do ask as many questions as you possibly can through the chat panel. We'll be coming back, or I'll be coming back to chat with Simon and Donna after the presentation to do the live Q&A. My colleagues will be available to answer any questions that you have throughout the evening. Certificate links will be available at the end. I'm saying that now. Everybody asks throughout the presentation, but do bear with us. We'll put a link at the end of the presentation for that. Bear with us if there are any technical issues. We say this all the time. We are working from or presenting from home, and so these things do happen, but we do have contingencies should that happen this evening. Without further ado, thank you all for joining us. I'm going to hand you over to Simon. Good luck, Simon. Good luck, Donna. I'm looking forward to the session this evening, and I'll see you after the presentation for the live Q&A.
Thank you very much, Alex. Thank you. Thank you as well to Wound Care People for inviting us along this evening, and obviously Coloplast for sponsoring this event, as Alex said. So I am Simon Barrett, as Alex says. I've been a practicing TVN and wound care specialist for, this is my 21st year, 21 years long. So I'm going to crack on and get into this presentation for you. Obviously, as Alex said, it's removing the barriers to wound healing through simplification. And I think that's really relevant at this current time, especially with us going through the pandemic 2020 and into 2021. You know, there's been a lot of change and there's been lots of opportunities as well. So hopefully the presentation will be something that you'll maybe reflect on. You may learn little bits, but we'll see how we go. So thank you very much for joining us. So the objectives for this evening are understanding the principles of wound bed preparation, exploring current methods of wound cleansing and debridement, and what level of practitioner can debride. And it's always going to be an interesting question, that, and hopefully I'll be able to answer as we progress through. Supporting the continuity of care and sharing best practice through a few clinical case studies that myself and Donna and a couple of my colleagues in Humber, which I'll name very quickly now, is Adele and Sophie, have helped me with as well. So the key point to anything, and I think the sooner we all accept this and we all do it and we all document it, we'll have a much better outcome for all of our patients. So the holistic wound assessment should identify and address the following. Now, obviously the patient's got to be the central point, but we've got to think about what is the underlying disease. Is there anything that's causing the wound to be there in the first place? And if there is, what have we done to correct it? Have we worked as part of the multidisciplinary team to look at the nutritional status? Have we added proteins in? Should the patient be losing lots of protein through their exudate level? Have we considered the mobility and involved the physiotherapist to make sure that we've got good venous return going if we possibly can, with plantar flexion, dorsiflexion of the ankle? Have we looked at the wound characteristics? So we've done all the nitty-gritty bits, but if you like, the wound is the last point that we should be looking at. And what's the wound bed like? Is it sluffy? Is it good granulation? Is there epithelial contraction? What do we need to do to kickstart that wound back into a healing pathway if we possibly can? Have we considered the dressings that we're going to use? And is there any allergies to the dressings, to the devices? Should it be compression, etc.? And what's our plan for once the patient has healed? Or if it's a case of, are we trying to manage the symptoms? But we've got to decide that, and we've got to have a plan at the beginning. So invest to save, and by that I mean do this good holistic assessment, make a good diagnosis, make a good treatment plan, evaluate it, and if we do all those things right, we'll probably get that better outcome for the patient. We've then got to consider the psychosocial factors. So does the patient actually want to heal? There's a number of patients, it may be their only contact with the outside world if a community nurse or an allied healthcare professional goes in to make that visit. So they may like having a wound that allows them to have that outside contact. It might be such reasons as, unfortunately, if you have a wound, you can claim more benefits. So some patients will like to hang on to the wound for that reason as well. So we've got to establish at the beginning a good relationship with that patient. We get some aims and objectives, and we work together as a team to get the best outcome for the patient. We've then got to look at other medications or treatments that they might be having as well that could either affect or delay the wound healing process. The one that springs to mind and always does is nicorandil-induced ulceration. And obviously, if you've ever come across it, it's a cardiac drug, and it's used obviously for the treatment of cardiac issues, but unfortunately it can induce anal ulceration. There's evidence also to suggest it can cause and develop leg ulceration as well. So we've got to be really clear that we've got a good knowledge of the medication that the patient is taking whilst we're trying to treat the ulcer or the wound. We've also got to look at whether there's such things going on as chemotherapy, radiotherapy, because effectively you're introducing cytotoxic drugs which are going to delay that wound healing process. And there's many other conditions and drugs as well that we need to think about that could possibly delay that healing process. So I'm sure all of you have come across these sorts of challenges within your clinical practice, whether it's that sluffy wound and it's thick adherent custard and you need to get it off, and you have the challenge of how do I remove it? Do I go through autolysis and it takes weeks and weeks and weeks, or do I have other options in my toolbox? It might be that you have a necrotic tissue with bacteria trapped below, and again you've got to decide, is it safe and is it appropriate, and does the patient want this necrotic tissue taken off? Because necrotic tissue is sometimes formed, especially over heels, to protect that joint underneath. So we've got to be really careful as to whether we do or do not debride or remove that necrotic, dead and devitalized tissue. It might be hyperkeratosis, and you know, we think of the skin probably not as in the same way that we do a heart, but it's an organ that does multiple things. And if we looked after it as well as we should and hydrated it, then it will protect us and give us resilience to infection and many other things as it goes along. I always get the mickey taken out of me by my good lady about my tramline on my head. And it looks like, she always says to me, it looks like I've been decapitated. I've tried growing a fringe, it's not worked. So maybe I should have looked after my skin a little bit better, and it might have not been quite so significant now. Moving on then. So how does the wound bed preparation support healing? Well, obviously, if we clean the wound appropriately in a safe manner, it does reduce the risk of infection, and it does reduce the risk of bacterial buildup. It therefore would go on to potentially improve the healing outcomes, or at least symptom control, which could be malodor, it could be exudate, it could be pain. And the pain levels associated with the maceration as well. If we've got a bacterial bed, there's going to be an increase in exudate, which is going to be then pouring out from the wound bed over that peri-wound skin, and it could cause maceration, a little bit of excoriation, and unfortunately it could cause further breakdown of good tissue. So it's really important that we manage that wound bed, that we manage the patient, and we reduce the risk of further skin breakdown. And ultimately, if we do those things, it will improve the quality of life for the patient. The one example I always used to tell the story and have a little laugh to myself about was Friday nights was always shopping night for me at Morrison's after work. So I'd go along to Morrison's, and I could guarantee on an evening there was other chaps there, but usually escorting their elderly mums, I presume, around with them. And there they would be trailing along with crepe bandages with green Pseudomonas behind them. And I always used to think, please don't let that be in our organisation that they're walking about. So again, it's about improving that quality of life, making sure they don't have to have that thought of, you know, green bandages trailing along behind them, whether they've got malodor, whether they've got pain. None of us should have to suffer with that with a wound. So the next one, debridement or wound bed preparation. So what do we actually mean by the term debridement? And quite honestly, debridement is defined as the removal of dead or devitalized or non-viable tissue and removal of infected or foreign bodies within a wound bed or wound edge. Now, if you think about wound bed preparation, that encompasses that. So wound bed preparation is a concept emphasizing holistic, I stress the holistic and systematic approach to evaluate and remove barriers to healing and process to allow the wound healing to progress towards normal healing. So effectively, debridement is part of the wound bed preparation, and it may be that we're hoping, as I said, to symptom control, or we may be hoping to get towards healing full stop if we possibly can. So types of debridement, well, you're probably aware of many of these, but there's autolysis, which dates back to effectively first thought about 1961 with George Winter's work when he looked at pigs. He scored some insults, unfortunately, onto some pigs' backs, covered half the pigs' wounds with a film dressing and left half exposed to the air. And what he found was those that had the film dressings on, which created a warm, moist environment, went on to heal an awful lot quicker than those left open to the air. So from that day forward, effectively, we've looked at warm, moist environments, and that would kickstart the autolytic process because you create that warm, moist environment so that everything is brought down to the party. We just create a warm, moist environment with a good, suitable, appropriate dressing, and you would then hopefully get an improved outcome for your patient. There's biological, there's enzymes, there's mechanical, and there's sharp debridement. So I'll just break that down a little bit for you. So autolytic debridement is the process in which the body attempts to shed devitalized tissue by the use of moisture. So a dressing choice will support this. So if you was looking at this wound here, you could look at that and you'd say, well, there's probably 50% of it slough, and there's about 50% good granulation. The surrounding skin is quite well looked after, and there's some epithelial contraction. There could be some undermining as well, but a suitable dressing for that could be a biotin silicone that conform, and it'd conform to the wound bed as well. So you'd get that intimate contact. It'd create a warm, moist environment, and it'd promote autolysis. So the next one is biological debridement. So this is larvae or maggots, which are grown in a sterile environment and applied to the wound bed, and they digest the devitalized tissue. Now, I'm not sure whether you've ever looked at larvae closely. Obviously, going back 20 odd years ago, we used to put larvae onto vascular wounds. And what they had, I always thought it was two little eyes at the end of the maggots. And basically what it is two little hooks. So they hook onto the slough and they start to score backwards as the reverse. And as they're scoring backwards, they're releasing an enzyme which breaks down the slough, and then the little beggars go back and re-ingest the slough, so they end up a lot plumper. And then when they're finished eating the slough, they then start to eat each other. So you never have the same number if you're putting free range on as you would have put on. You only take off probably 10%. So you don't need to count them on, you just take them off at the end. As long as you hydrate them and keep them fed and watered, they'll be fine. Obviously, things have developed since then, and they now come in bags. So you don't get the free range, you don't get the loose ones wandering around the ward, around the patient's homes. So they're a lot more compatible for the patient. This type of debridement does not require extended competencies, but you've got to have that knowledge, and you've still got to have experience that you must offload, hydrate, and give them that nutrient of the wound bed. Otherwise, the larvae will die off. Very effective though, and patients do sometimes suggest they can feel them wriggling about. So not ideal in some circumstances for some patients. So the use of enzymes, it's performed by the application of prescribed topical agent that chemically liquefies the necrotic tissue with enzymes. So the one that springs to mind, and again, I laughed at myself because I had a bit of a bad experience with this, was Varadase, which is basically streptokinase, which is used for clot breaking down if you've had a heart attack. So the Varadase comes in a vacuum vial. You'd obviously draw it out, you draw it out, and then you inject it onto the carrier being the dressing, and it's then placed over the wound bed. So in them days, or the days that we used a lot of it, it was onto gauze. Now, I can't multitask. I remember pulling it out of this backed bottle and injecting it straight through my thumb, which resulted in an A&E visit because obviously injecting Varadase was potentially lethal to my heart. But I'm still here to tell the tale, so be very careful if you're using Varadase. It is a very good clot buster, but I sometimes question if it was just a wet to dry technique. this type of debridement does not need extended competencies, but it does need a competent person. So maybe I wasn't that competent person 25 years ago. Then we move on to mechanical debridement, and this is known as almost as the wet to dry. And we used to put wet gauze on, let it dry onto the wound bed, and then strip it off. Now, you know, if you've ever, I haven't, by the way, before I say this, if you've ever had waxing, I would presume that having this done to a wound bed is very similar to being waxed, which I presume is not a very pleasant experience, and certainly not for the patients, and hopefully isn't done anywhere else nowadays. There are other forms of mechanical debridement now in the form of hydrosurgery or ultrasound, and again, they're all licensed, but I would suggest if you are going to use hydrosurgery or ultrasound, again, you've got to be competent, you've got to have some education, you've got to have some training to be safe, because that hydrosurgical blade that's shooting the water at very high pressure is just as dangerous as a blade in the wrong hands, in fact probably more dangerous. So you've got to be really, really careful and have the appropriate training. So the next one is surgical debridement, and this is removal of dead and devitalized tissue using scalpel, scissors and or forceps just above the viable tissue. So we only cut back to just above the viable tissue, because obviously if we went too much further, we'd cause an awful lot of pain. Can be undertaken in conjunction with other therapies, e.g. autolysis, and this does require an extended competency. Again, you'd usually have to go away to some university, and you'd be overseen by, in my case, it was a plastic surgeon. And hopefully you're competent, you come back and you're a safe practitioner. It is very quick, it is very efficient, but it does run risks with it. So the next set of images, I'm not going to go through every one, but what I would say is to you, which one needs to be debrided? Well, there's an argument for all, whether it's because there's slough present or whether it's because there's a potential biofilm there. We can't see the biofilm, but we do know that potentially it's associated with the fact we've had a normally progressing wound and then it's become static. That could be the bacterial burden in the biofilm. So it's really important that we do good wound bed preparation, whether it's slough, whether it's dead and devitalized tissue, whether it's a biofilm. So biofilms, it says on the slide that 80% of non-healing wounds contain them. There's evidence to suggest that a biofilm could exist in a chronic wound up to as much as 100%. So all wounds that are chronic in nature could have a biofilm. It's a structured community, and the way I've always described it is like the Eden Project. If you think of the Eden Project down in Cornwall, it's basically big biodomes or greenhouses that allow plants to thrive in the UK where they normally wouldn't survive because of the cold and wet temperatures. So basically these big biodomes create a warm, moist environment for the plants to grow. And it's exactly the same with these polysaccharide coatings that go over the top of the bacteria, which are the biofilm that allows the bacteria to grow and thrive underneath. So it's really important that we find a way of disrupting that biofilm. So what does a biofilm do? It causes an increased bacterial loading. It increases the exudate and slough. It potentially creates additional malodor. There could be erythema, and there could be a delayed wound healing. So it's really important that we, actually attack these biofilms as safe and as appropriate as we can. What I always reference is if you were a vandal and you was down at the Eden Project, or you had a greenhouse or somebody had a greenhouse in the garden and you took a disliking to them, then you could throw a brick through the greenhouse and it would introduce the cold air, and that would therefore disrupt or destroy the plant life. Well, you could do exactly the same effectively to a patient, but not throw a brick at them. You'd need to disrupt that biofilm with some mechanical action and a debriding tool, and that would ultimately kickstart the wound potentially back into healing. So the international best practice for the management of biofilms is wound bed preparation to cleanse and debride and reduce the number of microorganisms, and that's done by disturbing and removing some of the biofilm, if not all of the biofilm. You've got that 24-hour window, so basically you want to remove the biofilm and then zap the bacteria with your antimicrobial dressing. So the infection management is to suppress the biofilm formation and reduce the existing biofilms and microorganisms. So that's your 24-hour window. And if you think about your teeth, you're encouraged to brush your teeth twice a day because you have naturally caring biofilms on your teeth. So you disrupt the biofilm, you put your fluoride toothpaste on, keeps the bacterial burden down and looks after the enamel. But you've got to do it twice a day because it will build up that plaque. Now, we can't put sustained release products onto our teeth in the form of silvers, PHMBs, honeys, iodine, such as, but we can put the fluoride on it, and that's why we need it twice a day. So just remember, you disrupt it, you've got a 24-hour window, you zap it with your sustained release antimicrobial dressing, and you'll dampen down that biofilm effect. You will have to keep mechanically debriding or wound bed prepping to keep that bacterial burden down. So you apply a barrier dressing to prevent maceration and the management of exudate. So you want something that's going to lock it in and prevent lateral wicking, because you don't want it to spread onto the surrounding peri-wound skin, causing maceration. So we're just going to play a short video for you, if you want, that introduces a new innovation, if you like, in wound bed preparation. So this is called the All Prep Pad. If you'd like to have a look at this video, and I'll come back to you when it's finished. Thank you.
Simplifying cleansing and debridement to support optimal wound bed preparation. Life is not straightforward for people living with chronic and hard-to-heal wounds, and many experience that their wound provides them with uncertainty, insecurity, and pain, making the right wound treatment a crucial step towards improved patient quality of life. Wound bed preparation is a beneficial step in the wound treatment process that removes bacteria and devitalized tissue, which can otherwise increase the risk of infection, delay the healing process, and limit the clinician's ability to complete a full wound assessment. Wound bed preparation, such as cleansing and debridement, is clinically proven to speed up wound healing for the benefit of clinicians and patients. Cleansing and debridement may already be part of your wound treatment protocol. However, some clinicians report key challenges with current solutions, such as limited functionality, low absorption level, and lack of usage control. This is why we have developed All Prep Pad. It is a cleansing and debridement tool to support optimal wound bed preparation, rated by clinicians as effective and convenient to use. All Prep Pad is suitable for a wide variety of wounds requiring wound bed preparation, whether it is non-infected, infected, or with suspected biofilm. Use All Prep Pad to cleanse and debride the wound bed, the wound edge, and peri-wound skin by gently wiping the surface of the wound. Loosen first or absorb first. It depends on the wound. All Prep Pad is 2 tools in one. It has 2 sides. Use the dark grey foam to loosen and remove non-viable tissue, slough, and skin scales from the wound bed, wound edge, and peri-wound skin, as well as to remove biofilms and microorganisms from the wound surface. The light grey softer foam has unique slits to capture and absorb exudate, non-viable tissue and biofilms for efficient removal. Finally, All Prep Pad has an ergonomic grip for ease of use and increased control. All Prep Pad, 2 tools in one, designed for improved absorption and ease of use. Support optimal wound healing by preparing the wound with All Prep Pad and then apply a wound bed conforming dressing, such as our Biotane Silicone or our Biotane Silicone AG, according to your treatment objectives. All Prep Pad, simplifying cleansing and debridement to support optimal wound bed preparation.
Hi there, I hope you enjoyed that video. I just want to now reflect on a couple of case studies that we did within the Humber region and the, well, Hull and Humber region. So this was done, these case studies, there was 50 case studies undertaken by myself in Humber and Adele and Sophie and Donna in Hull. So the first one is a mixed etiology leg ulcer. And I think sometimes, you know, pictures speak louder than words. So if you look at the 18th of December image, and then look below it at the 14th of January. So we're looking at basically a 3-week period effectively. And what happened was this patient had the all prep, had wound bed preparation, and that was the only variable that was added to his care on top of his compression and his contact dressing. He'd had these ulcers for in excess of 2 years. And what it actually did was it caused the wound to progress through to almost complete healing. But initially it was 7.5 by 4.5. It was thick exudate with signs of infection and 80% slough non-viable tissue. And it was removed at first debridement. And then by the 14th, it reduced in size to 5 centimeters by 1.5. And as you can see, it was very superficial. There's good granulation. There's a lot of epithelial contraction. And it prepared the wound wonderfully well. Patient didn't feel any pain or discomfort, and he was really pleased with the result because of the reduction in size. Now, it only took another 10 days after this, completely healed, tensile strength of the skin building up, and he was back into his hosiery and discharged from the caseload after 2 years. So it's about getting that assessment, that diagnosis, that treatment, and the treatment plan being the all prep pad in this particular case was the only variable. If you look at the second case study, again, it's a venous leg ulcer, had been on the books for nearly 4 months. And if you look at this image, it's taken on the same day, and it's got that very adherent superficial slough that's almost like a crocodile's second eye that you can't remove. It's there for protection. It's almost like we used to call a biofilm when we thought we could see them, but we can't see them now. 4 centimeters by 4 centimeters. And then by the 14th of December, so again, you know, we're looking at only a 2-week period, the wound had reduced in size, admittedly only by 0.5 of a centimetre, but that's significant after such a period of time of it being a complex, non-healing wound. The exudate level had reduced, there was 60% granulation after that 2 weeks. And this lady again went on to complete healing 2 weeks after this, after the continuation of the all prep. So it's been really good at the wound bed preparation. It's been really good at kickstarting the wound into action, and it's helped, you know, our practice and our patients. So I will now hand you over to Donna, who will take you through the next set of slides. Thank you very much.
Thank you, Simon. I can't promise that I'm going to be as entertaining as Simon, guys, but thank you for joining us. I just wanted to start really just demonstrating or understanding the depth of the challenge we do face. And this bar chart shows guests' findings and demonstrates the increase in all types of wounds. So the yellow bars show the number of wounds in different categories in 2012-13 in comparison to the blue bars, which are 5 years later in 2017-18. So in addition to the increase in number of wounds overall, we can also see that there's actually an increase in the number of patients presenting with wounds who also have a diagnosis of diabetes, and that's increased from 29% to 57%, which supports other predictions that potentially we're facing a diabetes pandemic. And as life expectancy also increases and the number of people being diagnosed with diabetes increase, then other healthcare professionals need to find a way of managing this increased demand without compromising our care. So NICE guideline states that all diabetic foot ulcers should be referred to the multidisciplinary foot care team within 24 hours. Now, I would argue that actually all foot ulcers, regardless of diagnosis of diabetes, should be referred to podiatry, as podiatrists can support in the management. We have advanced skills in vascular assessments, such as ankle brachial pressure index and toe brachial pressure index. But in addition, we have skills in offloading and that all important sharp debridement. The National Diabetic Foot Care Audit found that actually the time interval between that initial presentation of a wound and the assessment by the multidisciplinary team actually had the greatest impact on healing potential. And when we think about that, actually almost 80% of all diabetes-related amputations are potentially avoidable, then obviously that time to referral is key. So you might ask, why is the diabetic foot more at risk of ulceration than, say, somebody without diabetes? And obviously, if you've had any previous ulcer associated with diabetes or a previous amputation, then that underlying etiology remains, and so you have a high risk of potential further ulceration. But we also know that people with diabetes have an increased risk of peripheral vascular disease, and as Simon says, assessment is key, and if we can't establish a sufficient blood supply, then no wound is going to heal, unfortunately. In addition, though, with the diabetic patient, we also have to consider the effects of peripheral neuropathy. So somebody with diabetes peripheral neuropathy potentially could walk around on a deep foot ulcer or even a broken foot and be completely unaware because of what we call protective sensation. In addition, we also have to consider the motor neuropathy in the sense that they could develop foot deformities, which then creates additional pressures on certain areas, which then potentially could result in further injury. And patients are unlikely to limit their activity because pain isn't stopping them. Obviously, people don't sit in nice little boxes, and what we also have to consider is that somebody with diabetes also has a considerable high risk of complications, and that will also place them at risk of foot ulceration. So, as Simon has alluded to, the assessment is key, and one of my favourite sayings is that we should treat the whole of the patient and not just the hole on the patient. And the reason why it's important that there is multidisciplinary input into diabetic foot ulcers is we need to make sure that we optimise glucose control, we need to make sure that we address any vascular insufficiencies, and we consider all the other existing health conditions, because as we know, people don't necessarily live with just one disease process. So you might have vascular surgeons involved, you might have microbiologists, you'll have diabetologists, specialist nurses, and podiatrists, orthotics, people who can develop prosthetics or footwear, specialist footwear to offload at certain areas. And then also, we mustn't underestimate the nutritional deficiencies and consider referring to the specialist dietitians. So Simon's talked a lot about wound bed preparation and debridement, and it's been clinically proven that preparing the wound prior to putting a dressing on is key to healing. And this bar chart just shows that somebody who has had a diabetic foot ulcer, those that had debridement on a weekly basis healed within 21 days, as opposed to those who were only debrided once a fortnight, which was 76 days to heal. So that certainly demonstrates the effectiveness of appropriate wound bed preparation. And often in my own clinic, when we're doing dressing evaluations, we do often wonder that more intense treatment, so that regular reviews and also that regular podiatry input actually influences the healing process just as much, if not more, than the actual product that we're applying to that foot ulcer. So it's not what we put on a foot wound that necessarily heals it, but more what we take off. And we've already discussed the effects of bacterial burden on delaying healing and the importance of disrupting biofilms. Podiatrists are highly skilled in sharp debridement, and we can help remove any devitalized tissue. But obviously that requires training and skills, and it's not always available at every dressing change. But Guest also alludes to the fact that offloading is not optimized with all patients. In fact, he suggests that only 5% of patients actually receive appropriate load redistribution devices. So rest is the important advice you can give any of your patients. And we need to utilize devices such as soft cast devices or air cast walkers or total contact insoles. So what have we done differently? How can we embrace this challenge? Before COVID struck, we saw in our area weekly face-to-face multidisciplinary foot care teams, which were very centralised. We would all go around on the grand ward rounds together with a vascular surgeon, diabetes and infectious disease consultants. We saw community foot protection services that were helping to try and maintain foot health and prevent further ulceration. But a lot of these community services were often working in isolation. And the pandemic recently has just forced quite a lot of change, really. We've seen reduced access to medical appointments, reduced screening, especially in the diabetic foot. And we've seen the introduction of virtual multidisciplinary team meetings, which has enabled podiatrists to possibly go out and visit somebody in their own home, Skype call or Microsoft Teams call with a vascular surgeon and a diabetes consultant, and then come up with an appropriate plan for that patient. We've also seen a huge shift in patient empowerment and patients becoming engaged in their own care. And also, especially in my own service, where the podiatrists were redeployed to support with community nurses, we've seen the implementation of making every contact count. So if you're going in to do a foot dressing, then potentially you could administer the insulin at the same time. So a real greater utilisation of skill mix. And this is something that, you know, we probably do need to increase as well. So I just wanted to share with you some of my experiences of the Alprep pad. The video that you've seen was actually one of our patients, and she was a young lady who was only in her 40s. She'd had a previous amputation of her hallux and then a more recent second toe amputation. As you can imagine, at that age, it's quite traumatic to experience that. This lady was very self-conscious, very upset that she was unable to wash her foot. We often advise patients to keep their feet clean and dry and not change the dressings themselves. And I think we underestimate the impact that that has on their quality of life. And any management plan, you are more likely to get patient adherence if you're engaging with them and you're involving them in the care. And that lady actually psychologically really benefited from visibly seeing the effects of the Alprep pad. She felt much cleaner. She felt like it was getting rid of the smell associated with her wound. So these images are one of our case studies, and all our case studies that we selected. And I just want to say thank you to the rest of my team because I couldn't do this without them. But most of these case studies were patients that actually we were kind of stuck with in the sense that we didn't really know what to do. Podiatrists are really good at picking up a scalpel and sharp debriding, but you know, when it comes to somebody who potentially is experiencing pain and that limits that sharp debridement, then it's almost a shock to the system because it's not that common in the diabetic foot clinic. So this image that you can see now is a gentleman who was 58. He'd had a traumatic wound to his right lateral ankle. It was following a fracture of his ankle, and he'd been off work for a month with this already. And that's quite important as well because, you know, he's keen to get this healed up as much as possible. As you can see, there was a very thin layer of slough when he first presented on the 7th of January. Extremely painful, sharp debridement wouldn't have been appropriate in this case. And after just 3 weeks of weekly using the Alprep pad, the wound bed was so much cleaner, and it did actually go on to fully heal within a few weeks later. And I just want to add that actually this gentleman's care, following the initial assessment and the implementation of the management plan, most of this work was done by our podiatry assistants at the diabetic foot clinic. So Sadie and Zoe were able to use the Alprep pad safely under the supervision of a podiatrist and then go on to dress. So it really does benefit that utilisation of appropriate skill mix. And finally, this case study was a gentleman who'd had a rub on his Achilles tendon area. And as you can see in the first image, he tried to manage this for 9 months himself. with various dressings. Obviously, he's neuropathic, so he didn't have much pain in this area, and he'd worn the shoes to that extent that he'd rubbed and rubbed as deep down as tendon. Now, it's quite daunting even to an experienced clinician who's used to sharp debridement to debride slough that's adhered to a tendon. And obviously, we don't want to cause any further trauma to that area. So our options for this gentleman was larvae, which not all patients are keen to rush in to use larvae. The thought of it can make some patients squirm. But also there's a delay in that treatment because you have to order it and then you have to get nursing in place for daily dressing changes. So as an initial first off treatment, this was something that we could offer him immediately. And as you can see, 3 weeks later, the slough is starting to lift away from the tendon. And finally, a more recent image I've been able to capture. Yes, it's not fully healed. Yes, it's still got a way to go, but the tendon's no longer exposed. It continues to improve. And this patient actually said that he really, truly believes that the use of the Alprep pad was the turning point for this wound to progress to a healing stage. So what's the vision for future in delivering wound care? I think the key is continuity of care. Wound bed preparation should be performed at every dressing change, and it doesn't necessarily need to have a skilled clinician. You can assess somebody, you can put an appropriate management plan in place, and then we can utilise our healthcare assistants appropriately to do those in between dressing change without compromising that wound bed preparation. We need something that's fast and effective. An Alprep pad certainly takes an awful lot less time than sharp debridement, and it's safe and easy to use. We could run parallel clinics. So we're having a highly experienced senior member of staff alongside a healthcare assistant, and that would enable us to increase capacity. And we can also support self-care and reduce the risks associated with sharp debridement and also the costs of disposable instruments and or sterilisation. So I think it really does have potential. Thank you.
Thank you, Donna. Thank you, Simon. It was a really great presentation, and I've been watching throughout, and the audience has been very engaged. So for all of you who have been watching this evening, thank you very much for all of your many questions. I am going to start just by saying, because we've had quite a few people who have asked whether they can get a sample of the product. So you can actually get a sample of the product. Coloplast have been very kind and said that they'll send those out if you want one. And the way that you get one is in a few moments we'll put up the link to the certificate of attendance. And when you fill that in, you just fill in the address that you want it sent to. And there's an option there, look out for it. There's a specific option which says that you're happy to be contacted about this by Coloplast, and then they'll get one in the post to you. So thank you both again. How was it for you both? First Facebook Live, you both did very well. Simon, how was it for you?
Yeah, we were Facebook Live virgins, I suppose, but yeah, it went fairly well. Some things don't go quite as you'd like them to go because you forget things in the excitement of it all. But yeah, generally speaking, it was okay, Alec. Thank you. Good.
And you, Donna, you okay?
Yes, I'm happy now.
Good. I tell you what, then let's get cracking with the Q&A, because we've got loads of questions here. So the first question is for Simon, and this is: Is it safe to debride all necrotic, sloughy wounds?
I would probably say no. You've got to go back to your assessment and make sure you've got a knowledge on why you're wanting to debride. Is it safe because you need to know, is there a vascular component? And I would use the terminology or the saying, only open it if you know what's underneath, because if you don't, you'll open a can of worms that you can't close. So certainly where there's a heel wound that's got necrotic tissue, leave it, refer through to podiatry, refer through to vasculars, and let the experts take over.
Yeah, cheers. I was actually just gonna pass that over to Donna as well, thinking about sort of heel wounds. What's your view on that, Donna?
Well, initially you need to make sure it is necrosis. I've had a few times where I've had patients refer to me and it's actually just dry blood that's there. So definitely get a podiatrist involved. I think you need to think, what am I trying to achieve? If there isn't, as Simon says, if the vascular supply is compromised, you'll remove dead tissue to just create another wound that's not going to heal. So it's just thinking about what you want to achieve and what you're able to achieve with that patient status.
Okay, brilliant. Yeah. So question number 2, this is for you, Donna, and this is, can HCAs debride and clean safely using the pad?
Definitely with the pad. I don't think that they should be making those decisions. I think as we've talked all the way through tonight's presentation, that the most important thing that you can do is the assessment and then the wound bed preparation. And actually it's like anything, if you prepare something well, then you will get good results. You know, no dressing in the world is going to work effectively on something that has got a good blood supply and that's got a biofilm on there. And what we know is biofilms form really quickly. So the more often we're cleansing that wound bed and disturbing that biofilm, the better.
Okay, yeah. Brilliant. Question number 3, this is from John for Simon. This is, can you define what you mean by extended competencies, please? Extended
competencies, well, it depends on which type of debridement you was using. And I'm just going to reflect back here to some JCN roadshows that we used to do a few years back. And the question I would ask John was, in the audience, how many people here think they can debride? And out of 150 people or so, you would probably get 1 or 2 that would put their hands up that thought they would debride. So in actual fact, what they didn't understand was what we actually meant by debridement. Did we mean autolysis, mechanical, sharp? So your competencies would be based upon the type of debridement that you was using. So if you was to go and undertake sharp debridement, you could or you would be a podiatrist and you'd done your degree that way. Or if you was a TVN and you did it my way, we had to be competency observed by a plastic surgeon at the University of Nottingham. If you was competent at doing wet to dry, which hopefully nobody is, it was somebody who would observe you and tick your box and say, yeah, he was competent at that. And the same with, if you was using hydrosurgery, then I would suggest there should be a standard operating procedure in place with some competencies that are designed within the trust to make sure you are a safe practitioner. It just depends on the type of debridement that you're doing.
And is it just patient specific, or did certain trusts have their preferences in a particular debridement method?
I don't think there's a specific choice. I mean, obviously you're limited if you've only got 1 or 2 TVNs within an organisation that can debride, then you're limited by your choice there, unless you can refer through and it's a foot ulcer, then you can refer through to podiatry as long as the pathway is in place and they're willing to accept whatever that referral is. So it just depends on the type of wound and that debridement, really.
It also depends on the resources you have. So not all, say, diabetic foot clinics have access to a VersaJet, say. You know, you have to work with the resources and the armory that you've got. But likewise, that's also work with the skill mix that you've got as well.
I mean, if you was to consider the old pad prep pad, Uncle, try that's a tongue twister, that one, isn't it? If you was to consider the old prep pad, then basically you don't need to be competent other than be able to, are you competent enough to assess and confident enough to assess this patient, to make a diagnosis? Can you determine whether this is peripheral arterial disease, or is it pressure, or is it something else? And as long as you can differentiate between that, you then come up with your treatment plan, which your treatment plan will be debridement or wound bed preparation using one of the choices. But with the old prep pad, things have moved on. And as Donna said, you can be a healthcare assistant who's been observed, signed off, and off you go. You can use the old prep pad comfortably, safely, without causing any damage or detriment to your patient or your wound.
Yeah, brilliant. So we'll move on to the next question. This is for Donna from Emma. This is, I've been told to encourage the wound to bleed during surgical debridement of diabetic foot ulcers. in order to aid healing process. Is this correct?
Yeah. Obviously, if you take it back to healthy tissue where it's bleeding, then it's more likely, you know for sure you've got rid of all the devitalized tissue if you create it to bleed. And obviously that's what happens when somebody goes to theatre and has surgical debridement. Obviously, though, you would only want to do that if their vascular status was okay.
Okay, thanks. So I've got a question here for the two of you, and this is when we come across an ulcer on the foot, who should we refer this to, podiatry or tissue viability? If I ask you first, Simon, I'm not sure if this is the same question, but when I was watching earlier, I saw somebody made a comment which was very similar to this. They questioned, why would you refer it to tissue viability if it's on the foot, if tissue viability are then going to assess it and then send it over to podiatry to treat?
Well, there's a couple of ways of looking. Yeah, there's a couple of ways of looking at this, Alec. And to be honest, we've had this conversation today in our pressure ulcer review and learning panel, because the pathways into podiatry are different. It's as Donna alluded to, you know, and I would like to think Donna's an expert when it comes to care of the foot, and especially the diabetic foot. So from my point of view, I would like to make sure that I gatekeep those patients that need to go through, for those that really do need to be assessed because of their limited resource. Yet in another part of our organisation, the commission that all podiatrists see all wounds that are on the feet. Now, I'm not so sure that you need to see a podiatrist for all foot wounds. I think it's a specialist service that offers, you know, specialist advice and support. And I think we should be collaborating and working together. For me, it's not about who it should belong to. It's the pathway that's in place and the communication that's held between the two services.
Okay, and yourself, Donna, what do you think?
So it's understanding each other's different roles. And when I look at any foot wound, I think, what do I add to this management plan? So if somebody needs sharp debridement, then obviously I would argue that podiatry is the best place to deliver that. Sorry, Simon, but we are. Any wound that's on the underneath side of the foot, so any plantar wound needs offloading. If you've got a wound, I'll just give you an example here. I got referred a diabetic patient, diabetic foot ulcer supposedly, and it was basically on the top of the foot, in between the two toes, and it was caused because this individual had a highly exuding leg ulcer, and the exudate was running down the foot into the toes, and obviously in between your toes gets moisture anyway, and that area started to break down. Now that, to me, although it's a foot ulcer on a diabetic patient, was the moisture lesion, and that is best placed in tissue viability or community nursing, because we don't, or not all podiatrists are trained in compression bandages. So it's, yes, I want to see that patient and assess them and see if I can add anything to their management plan, but actually the management might not sit with me.
Yeah,
it could be about addressing the root cause. I was thinking, Alex, that's the problem. And that's why I think it's really vital that we have good communication between both services. We should be collaborating.
Yeah, okay, thank you both. I thought I was going to have to sort of be some sort of virtual referee then between the two of you. Thank you for that. The question number 6, this is from Gina for Donna. If there's an ulcer to the foot caused by pressure and they have diabetes, is it recorded as pressure or diabetic foot ulcer, please?
Well, and I do question whether guests' data and results is that we've changed our way of recording things. I think we need to go back again to the underlying etiology of that wound. So you could have, so I presume, Gina, you're talking about maybe somebody who's been hospitalized and developed a pressure ulcer on the heel, say, but yet they also have a diagnosis of diabetes. That to me would be classified as a pressure ulcer in a diabetic patient. If they've got pressure associated with altered mechanics, which is caused by peripheral neuropathy in a diabetic foot, that's a diabetic foot ulcer. So no one sits in boxes. I have to confess, I'm not one for categorizing. I actually don't care what we call it. What I want to do is just heal it up. So sorry.
Yeah, it'd be nice if the whole NHS thought that as well, wouldn't it? So the next question, this is from Gail for Donna again. So what do you mean by correct products for washing?
Oh, did I say that?
Yeah, I must admit, I think that it's a bit vague there, because somebody's obviously caught something that you've said at some point. I mean, if we can come back to that, because I usually say this, I don't think I have yet, that we've obviously got lots of questions coming through. We've got one or two more that we can do this evening. But any questions that we haven't got through this evening, what we do is we put them all into a document, and then we, alongside a copy of the video and the slides for the presentation, we put a document which has all of the questions with the answers on there. I think, did I just buy you some time, Donna, to
you did.
the answer to that? Is that good?
I mean, I can't believe I said that, because I don't really...
I don't think you did.
Did you say it, Simon?
But
I might have said it, but if I did say it, I wouldn't have said washing, I'd have said cleansing. So
yeah.
The way I would be thinking about this, if it's a surgical wound, it should be a sterile solution. If it's a chronic wound, certainly a venous leg ulcer or such like, it should be tap water that's run hot and cold, run it for a few minutes, make sure there's no bacteria, Pseudomonas in the nozzle, and that's absolutely fine for chronic wounds. What I would say is it's more important the device that you use for cleansing or debriding or wound bed prepping, because you don't want to shed any fibres. That's the key point. I got a Datix came through the other day, and the nurse had said she'd cleaned it with cotton wool. Cotton wool. I thought, hell, cotton wool.
And I think that's the bit, if I referred to a product, I think it would have been the product that you utilize to cleanse. So either a pad, a debridement pad, or as Simon says, sterile gauze used to be used years ago. Certainly nothing that leaves any fibres, and I certainly wouldn't suggest that they. I think when we're looking at patient adherence and patients want to bathe their feet, we certainly wouldn't recommend any toiletries or bubble bath or any astringents. I hate the smell of TCP in my clinic and Dettol, but people still do it. So usually we would say to somebody to keep a wound clean and dry. Just
not cotton wool.
Not cotton wool.
Not cotton wool. Okay, so we're on to the final question. This is question number 8 from John for Simon, and this is: how can you recognise biofilm when looking at a wound?
Good question, John. In a few years gone by, they used to tell us that we could see biofilms. Now, the only way that you could see a biofilm if you've got microscopic vision, and as you can see by my Beverly Becks, unfortunately, I've not got microscopic vision. So the only way that you can tell is if you recognize some signs or symptoms of the wound, in that you've got a delay. So the wound was progressing normally down a healing trajectory, then it stops, and it'll stop dead, and you'll get an increase in exudate, an increase in malodor, and possibly some pain with that slight inflammatory response. So if you see that in your wound and it is chronic that was progressing nicely, it's probably a biofilm. And the evidence would suggest, like we said, it's anything from 70 to 100%. And so it would need some good wound bed preparation to disrupt it and kickstart it on to healing or symptom control.
Brilliant. Thank you, Simon. And thank you, Donna. Really enjoyed talking to you both, and I really enjoyed the presentation. And just judging by the comments, as I said earlier, I think everybody else watching at home has enjoyed the session as well. Thank you very much to Coloplast for supporting the event. We can't provide these free educational events without the support from industry, so we do appreciate Paddy and his team, who have been working tirelessly. I know they've been working this evening behind the scenes as well, so thank you very much to them. Thank you very much to everybody who's joined us, and there should be a link to your certificates to download now on your screen. As I mentioned earlier, if you do want to get a sample of All Prep, then you can either contact your local Coloplast representative, or you can fill in the information when you go to download your certificate. Bear with us, because with so many of you watching, if everybody clicks on the link right now, it may slow the system down. So if you get an issue when you go to download the certificate, try again in a couple of minutes once some other people have done it, and it'll be fine. Our next event now is on the 5th of May, which is Wound Healing, a new animated way to learn. Our company, Wound Care People, with some partners, will be launching a new animated way to learn. So please do sign up for that. Thank you very much all for joining us. Thank you to my team for working this evening, and we look forward to the next session. Good night.
Thank you very much. Thank you.